Hi, Unpain Clinic community. Today I have a very special guest with me, Dr. Stefan Buntrock, a urologist from Germany that is going to share with us anything that has to do with men's health. So welcome to Unpain Clinic podcast, Stefan.
Thank you, Uran. And you pronounced my name beautifully.
Thank you. My pleasure. Sometimes I have trouble with that, but I know you long enough that it's easy to pronounce your name.
Okay. It also means something. So bunt means colored, and rock is like a skirt. So it's more like a colored skirt.
Okay. Wow. Yeah. See, it's when names have a meaning, that makes it even more beautiful. You know, it's easier for people to remember them. So Stefan, what do you do for people?
I'm a urologist, so I'm a doctor, and I'm working in my own practice in the middle of Germany in a small university town by the name of Göttingen. I've traveled the world because I was growing up in my medical years with the goal to gather knowledge. I think this is how they did it in the old times. So they just traveled from facility to facility and just gathered as much knowledge as they could. So I went to different places, and to my surprise, every place was different, and every town had their own diseases. It was crazy. So I gathered as much knowledge as I could. And then in the end, like 10 years ago, I specialized in sexual medicine. And then 7 years, almost 8 years ago, I opened my own practice. So I'm specializing on sexual medicine, but I'm a urologist. I did all the classical urological stuff. I have the surgical education. I did everything. So, but now it's just non-surgical sexual medicine.
Wow. So I have and this is for people to understand more, and even for me. So when we say urologist, does that mean urologist only treats men, or do you treat women too, or is urologist for women too?
Urologist is about the urinary organs, which is the kidneys and the bladder and the prostate. And of course, also women have a kidney or two kidneys and the bladder. And even children have kidneys and a bladder and infections and stones and everything. But I think it's more or less our fault, at least here in Germany. We promoted ourselves as the counterpart to gynecologists. And I think being the doctor for men kind of blurred the picture, because now people think we're doctors for men, but we are doctors for all genders and all ages. But in my office, it's like 90% men. It's just the way it is.
Yes.
And then urology also deals with andrology. And maybe this is why, because andrology is men's health. So it's procreation, men's genital organs. That's also urology.
Thank you for this explanation, because this is very important for people to know that if there's any urinary tract issues, urologists can help, right? It doesn't have to be just OBGYNs.
There's one thing people always get wrong. So urologists, we don't deal with hemorrhoids. These are other guys. So I always get these questions about hemorrhoids. No, we don't do that. That's proctologist in German, or in internal medicine, gastrointestinal doctors. They do this stuff. We don't.
Yeah. Okay. Good point. So we have the anatomy, we have the pathways now clear. So today, why I wanted to do this episode, this interview with you, is I just wanted to shed some light in like men's health condition, and the three main ones, like the Peyronie's, ED and chronic
Hmm.
prostatitis, or like a pelvic pain syndrome. And both in this case, being man here, we are a little bit more hesitant when it comes to our health. We kind of wait till the last minute. So
Hmm.
if we can change one man life with this session, I'm so grateful. So the main one that I hear a lot, we hear a lot, we see a lot, is erectile dysfunction. So I want to
Hmm.
start with that. So
Hmm.
what is erectile dysfunction and what causes erectile dysfunction?
Well, officially, erectile dysfunction is the inability to obtain and maintain an erection firm enough for intercourse. That's the definition of erectile dysfunction.
Okay.
We have traditionally had erectile dysfunction as the main problem of the older male, of the aging male, who is approaching 40 and older. But for like 20 years or so, we see a development in also younger men. So in their 20s and their 30s, now they approach with erectile dysfunction, which is a new development. We didn't have that. And we think this is mainly because internet pornography. So it changes the way people look at sex, and it kind of seems to desensitize men so that they are not aroused enough to have intercourse. So lots of this ED stuff in young men is most probably due to internet pornography. So when men get older, then changes in bodily function, they begin to appear more often. So we are talking about the tissues being less firm, less responsive, which is kind of normal. Like, for example, beta receptors. I think everybody knows somebody who has a high blood pressure and is put on beta receptor blockers, which is a kind of medication to lower blood pressure. And beta receptors are very important for erections. So if you don't have them, you don't get an erection. And this is why beta receptor blockers, they cause erectile dysfunction. With one exception, there is a substance called nebivolol, which is a beta blocker, which doesn't do that. So whenever I get a patient who is on beta blockers, the metoprolol, atenolol, the classics, I try to switch them to nebivolol because it doesn't have this side effect this much. So when beta blockers, they get lost when we get older, which is a problem. So the penis gets less responsive, then hormonal changes kick in. And of course, everything that's got to do something with our way of life. So in the Western lifestyle, we eat the wrong stuff, we gain weight, then we enter into a state which is called the metabolic syndrome. And this is a vicious circle. You just, if you start this, the spiral goes down. So it starts with obesity, and then you get glucose intolerance, which leads to diabetes, and diabetes damages nerves and damages blood vessels, which is bad for erections, and diabetes lowers your testosterone, which is bad for erections. The metabolic syndrome elevates your cholesterol levels, which is bad for blood vessels because you get atherosclerosis, which is bad for erections. So everything leads to something that's bad for erections. Then you get obesity, you get sleep apnea, which is bad for erections. Sleep apnea also has an impact on your gut. This is a quite new finding that we have in science. So if you don't breathe properly at night and you stop breathing, which is a lot of people who have this, but they're not aware of this, because if you have this, you don't know. So only your partner in bed will know, because they think you're dying because you're not breathing anymore. And then if you have this, it has an influence of the gut because it's kind of gets leaky. So toxins from the bacteria from your gut leak into your bloodstream, which causes chronic inflammation, and chronic inflammation is not good for erections. So all of this, like, is playing against you once you have this. And this is what's happening in people when they get old, and then they get medication. I just told you about beta blockers, and the medication in itself, they can cause erectile dysfunction. And so that erectile dysfunction increases the older you get. And you can say 40% at the age of 40, and it's almost 80% of the age of 80. And if we get 100, so it's 100% more or less. There are some exceptions, but I think it will, if you get old enough, you will get it.
Wow. So in reality, erectile dysfunction is not just this. It's what I was thinking is just not one diagnosis. It's actually a side effect of many things that happening in the human body.
Yes.
And that's where it show up.
And also, as I mentioned, psychology plays a big role, especially like psychogenic ED. So when they say it's all in your head, I don't really like it because it suggests that maybe you have some mental illness or so, but it's a profane thing that happens. If you are very eager to perform and you think you have to show something to your partner, then you activate the wrong part of your autonomous nervous system. So we have a nervous system that makes our body work without us having to think about it all of the time. And we have two parts, which is the activating part, which is called the sympathetic nervous system. And then we have the relaxing part, which is called the parasympathetic nervous system. Actually, for sexuality, we need both, but for erections especially, we need the relaxing part, the parasympathetic nervous system. This is why we have nighttime erections, because when we sleep, parasympathetic activity is at the top, so we get an erection. When you want to perform, you activate your sympathetic nervous system. It doesn't work because sympathetic nervous activity, that's fight or flight. So we have ancient parts in our brains that have ancient function. So we are like cavemen in some parts of our brain, meaning that if the bear approaches us, we want to run away or we want to kill it. And if like if it's a woman, the hot woman is approaching us, we want to show off or something, we get very eager to perform. And this is the same effect. So fighting or running away is not good with an erection. So nature has constructed us that we don't have erections when we are in this state. And this is why it's important to relax. So, but just tell somebody to relax. Like if I tell you, don't think about the pink elephant, all you want to do now is think about the pink elephant. So it's not as easy as that.
Yeah. You know, as you're talking, I'm kind of translating this in my mind, which I never thought about it. It's almost like doing yoga, but at the same time, like lifting resistance training, right? Or doing yoga in treadmill.
Yes.
So that's what you need to do pretty much to have a good erection. You know, it makes sense because it's interesting as a humans, everything around us has changed, but our biology, our physiology hasn't changed. So we still have those primitive mechanisms inside. And then now, as you mentioned, you know, pornography, or there's so many other stimuli that are affecting our body physically, emotionally, psychologically, because when you mentioned all the factors that affect, you know, erectile dysfunction, and then you mentioned, you know, psychological effect, we have to remember that if you know, smoking, alcohol, poor habits, poor like a high level of glucose, if they actually affect your tissue physically, they're going to affect your brain too. So even indirectly, everything kind of boils down to the ED. So we know kind of you gave us a good general idea of like why this happens. Is there a hope for this condition? What is the solution? Like, what do you recommend to help those people usually, or what do you do?
There are several things to do. First of all, we want to have a diagnosis.
Okay.
And it might be as simple as a pelvic floor overactivity. We're going to talk about this in a second. But generally, I advise people to lead a healthy life, which is very difficult because Western lifestyle is defined by unhealthy food, by unhealthy habits. We sleep too little. And as you said, we smoke too much and we drink too much alcohol. And we eat the wrong food and we don't move. And all of this is bad. So if you want to maintain an erection, I think you have to discipline yourself to eat the right food. And whenever I tell people what they should eat, they don't like me anymore. I have a YouTube channel and I get very nasty comments when I recommend what to eat, because you want to eat unsaturated fats, whole grains,
Yes.
legumes. You want to drink water. You want to avoid soft drinks. And all of this means, yes, carbohydrates are good for you. It's not a bad thing. We need carbohydrates, but we need complex carbohydrates. So not the easy carbohydrates with simple sugars, sweeteners. These are also carbohydrates, but we need complex carbohydrates like from whole grain, which is very important. And this is what people don't understand. And we need unsaturated fats from, like, for example, olive oil, stuff like that, from nuts, because they will increase our health. We don't need saturated fats from processed foods, and we don't need saturated fats from meat. So you shouldn't eat meat every day and not 3 times a day. If you just look back at how people were living like 50 years ago, there was one little piece of meat once a week, and this was shared between the family. So
Yeah.
normally the husband would get half, and then the wife and the kids would just share the other half. This is how much meat they consumed back then, and they were much healthier than we are now today because we have abundance of meat. And if you look back to where these recommendations come from, there's a milestone study. It's called the 7-country study, performed in the 50s from an American researcher who traveled the world just to find out how come some people live longer or in some countries than other people. And what he found was that the Mediterranean diet, as that he found on the island of Crete, was the most healthy diet. By the way, the name of this researcher was Ansel Keys. He was the one who introduced the construct of cholesterol into our today's thinking. So when we say cholesterol is bad for you, this goes back to this 7-country study. And they made protocols. So he just asked the people, what are you eating? And they put it down on paper and handed it in, and he analyzed this. And the Mediterranean diet was a calorie-reduced diet because they didn't have that much to eat. And if you look at the old protocols, it says, I'm hungry, which is scribbled on the side of this paper, because they didn't have enough to eat. And they didn't have meat, only very little meat, and they did have very little fish. So most of it was nuts, olive oil, legumes, vegetables. That was the majority of what they ate. So I think a calorie restricted diet is very important, especially if you look, if you count your calories. We have calculators on the internet. You can download an app where you can calculate this. I did this last year. It was incredible how many calories I ate, and it was so little fun to eat the right amount of calories. Just if you calculate what you have to eat, and then you see, like, I was eating a bun without butter, a little jam, and it was like 600 calories. I couldn't believe it. And this is one of the problems. So you have to exercise, you have to know what you're eating. And this will help to increase the ability to have erections for a longer time. And you have to stay away from smoking and alcohol, as you said. But the big problem is we are getting older, and you can't prevent age. It's just not possible. And then you will risk to have not so good erections. So this will not help in every case. So you have to do something else. And I think you have to train your penis. So how do you train your penis? It's mostly by sleeping, believe it or not. So nature has constructed us in a way that we have these nighttime erections, and nighttime erections are very important because they fill the penis with blood. And this means nutrition, oxygen, all the good stuff that the cells in the penis need to survive. Because if you just think about it, I think it's per hour, it's about 4 to 6 milliliters of blood that's going through the penis. That's not very much. And you wouldn't be able to survive as a penis if you just get that. So you need erections with high amounts of blood flow to survive. So when we talk about training the penis, this is what we're talking about. We're talking about erections. So you have to sleep. You have to have a good quality of sleep, so avoid any kind of sleep apnea that we were talking about, so that you give your body the chance to have these REM sleep patterns. REM sleep is rapid eye movement. And when we dream, our eyes are starting to move. And this is when the penis starts to erect. I know from my videos that many people don't know the difference between muscle and muscle, because we have 3 kinds of muscle in our bodies. So it's, when people think about muscle, it's commonly skeletal muscle. So when I move my arm, I'm using skeletal muscle. But then we have another kind of muscle, which is heart muscle. So it's a very special kind of muscle, which is only be found in the heart. And then we have smooth muscle, and smooth muscle is a lot of muscle in our bodies. So it's what we have in the gut, and, for example, what we have in the penis. So you can't train smooth muscle the way you train skeletal muscle. So it's no way you lift weights with your penis or something like that. Or if you work out, it wouldn't do any good for your penis, because this is smooth muscle. And the way you train smooth muscle is by making it erect. What I recommend, and we're going to talk about shockwaves, I think some kind of cucumber mask to apply in regular intervals would be a good thing. So we know that regenerative therapies, they make our tissues last longer. So for example, if you do shockwave therapy, we know that this is rejuvenating the penis. So you get more blood vessels, you get stem cell activation, you get neural increase of neural velocity of the nerve impulses, and everything like that, which then promotes penile function. So in a way, I think it could be a good idea to do like a short bout of shockwave therapy, like once half year or once a year, just to make sure the penis will continue to work. This is, by the way, this is not evidence-based. So this is experience-based.
It's interesting because it's shockwave. It's been used in Europe, I think, since 2010 for treating erectile dysfunction, what they call it vasculogenic ED, which is due to poor blood circulation, or what I just learned now from you, that there are 2 main things. It's like, this is just to simplify it for men. So if you want your engine to work properly, you have to put the proper gas, which means it's like the food, right? And then is the sleep, and then you have the activity part, and then what it just came to my mind is that intercourse is not just that physical, or it's not just that physical aspect of the working out the penis when you have sex. It's actually more the blood circulation that it's coming in that area and supplying, the penis with the nutrient and oxygen that it needs.
Mhm.
So if you don't do pretty much those things yourself, then obviously you're going to need the help from modalities nowadays, therapies, or anything, external stimulation. So with Shockwave, because we have been doing Shockwave at Unpaying Clinic for ED since 2015, 2014, 15. I think we were one of the first clinics to start doing this in North America, especially in Canada. So what we tell people is, okay, we're going to do the treatment phase where we try to go and restore the erection or improve. And then we suggest them, okay, do one session every 3 months, 6 months. But then I tell actually clients, I say, hey, even if you don't have any issue, just go and actually do it for yourself. It's for the health of the penis. So it's like, that's just to maintain it. So
Yes,
thank you for that.
I think this is one of the important lessons that once tissue is lost, it's very difficult to reactivate that and to
Yes.
regrow this kind of tissue. And if you have troubles with ED, you should act now. The earlier, the better. If you wait for years, it wouldn't work. And this is what I see in my patients. If you approach 70 or over 70, I have some patients who then at the age of 72 to 75 suddenly have a new interest in getting active, and they haven't been active for a long time. And what I see in many of these patients is something that I call the wheat bread penis. And this is the cellular mass in the penis, in the cavernous bodies, has become so thin, so lots of these cells have died. So if you squeeze the penis, normally you can't really squeeze it; it's firm. But if you squeeze the penis in these guys, it's like a wheat bread, a fresh loaf of bread that you can like press, and it gets so small. This is, to me, it's just a sign that lots of tissue has been lost. And then it's very difficult to rejuvenate that, because you have to think about the mechanism. Why is the penis erecting? And this has to do with pressure. So it's hydraulic. What happens is that blood enters the penis, a very large and high amount of blood at the same time. So the pressure inside the penis increases, and there is a small, let's call it a sock, which is around the cavernous bodies, which is called the tunica albuginea. And this is a very firm kind of structure. It's collagen. And this structure will then build a resistance to the pressure that's rising inside the penis. And taking these two factors together, it will hinder blood from leaving the penis. So the venous outflow will be closed because of the pressure and the tunica albuginea. And if there's not enough structure or not enough cellular mass inside the penis, if the cavernous bodies have lost a lot of structure, then the pressure will not be high enough to close off those veins. So what is happening is a so-called venous leak. So the blood will enter the penis and then will just go out again, because it can't be held inside the penis.
Yeah. Wow.
So this is why I'm saying try to treat that early and try to maintain good erectile health throughout your life. And by the way, good erections are commonly a sign of good general health. So if you have good erections, you can be pretty sure you're pretty healthy. It's not always true, but it's just a rule. There are exceptions, but I tell my patients that if good erections are always a good sign.
So should we say one erection a day keeps the doctor away?
Maybe two.
Or how many do? So if erection is such a good sign of men's health and positive sign, so why, Stefan, from all your experience, why men hesitate to go and look for care, to take care of this ability and yeah, but like of the erection? Like I know many men hesitate to, like, if they have a problem, they wait till it's too long or they give up completely. So from your experience, what have you found? Like,
I
how
think
can we
it's
actually convince a man to go and take action earlier?
that's a good question. I think there are two factors. The first one is that men are very hesitant to go and seek medical help, which is based in their role as a man. So you don't take things too lightly, I would say. So you just wait until it's very bad until you go to the doctor. This is how we grew up, and this is our role models, how we act. And the other thing is that this is a very big taboo. Still, I don't understand why, because we live in a totally sexualized world. So sex is all around us. But still, when it comes to a personal level, we have a tendency to avoid everything that's sexualized, and especially going to some kind of doctor and telling them that you have an erectile problem. And these two factors together, they make it quite hard for men to look for help. I'm not quite sure how to convince men to do that. I think maybe it has to do with transformation. So the way we traditionally approach men for their health, I don't think it's the right way to do it. It's more the approach. So when you do this, what's in it for you?
Yeah.
Less than saying, if you don't do that, then that is going to happen. That doesn't work.
Yeah. You know, I'm just thinking myself because men are genetically programmed to provide. You know, we are the providers. So if you're a man out there listening to this, it's like if you're providing for your family, you know, financially, you're bringing the money, you're supporting your wife and kids and your family, and you take action for that. If money, you know, goes low, you work harder to bring it to your needs, or you work constantly. And so remember this: if you experience erection, if you have the first sign of erection, is your body, it's going low, as we just learned. Like there's so many things that are going wrong, and that's why wherever you are in the world, you have to take action, because if your health goes down, everything is going to go down with you as the provider. So yeah, I hope this message ended up somewhere that they would take action, because
this is a very important point. I have this, I adopted this, as a matter of fact, from the German Navy. So they have a rule. It's called, they say it's one hand for the man and one hand for the ship. And if you think about it, it makes sense, because it's important that the man is able to work. And it's essentially that what we've been saying, only put in other words. So we have to think about that. If we are not functioning as men in a traditional role model, so we are putting the whole family in danger. So we have to see after ourselves to make the whole thing work.
Yes.
And this is what I was telling my wife the other day. She said that you can't tell this to your patients, because who is the most important person in my office? It's not the patient, it's me.
Exactly.
Because if I'm not there, if I don't look after myself and try to treat myself in a way that I can go to work, then there won't be any doctor in the office, so the patients will suffer. So in a way, it's like in the airplane. Like if the cabin pressure drops, whom are you going to put on the mask first? Not the children, you put it on yourself. Because then you can aid children, because if you're unconscious, the children won't be helped. No, it's the same kind of thinking. So sometimes you have to think in another way.
Yeah, and the other thing is, like, this is such an important, even for the relationships, because if there's no good, you know, sex during the relationship, it affects everything. It's you're not affecting just yourself, you're affecting your partner as well. And then that's spread out as a chain reaction. So yeah,
you could even say one hand for the relationship.
Yes.
and one hand for the man.
Okay. You know, okay, I'm gonna share this since we start talking about this, because this is all about man health and relationship and family health. So every weekend we go out to eat with the family, my wife, and then it was actually Sunday, so I took my wife to her favorite place to eat, and then we were driving back, and she was very happy. The stomach is full, and we were just teasing. I said, "Okay, so what is missing here? What is something that would complete the day?" And she said, "You know what? Sex in the end." So then I said, "Oh my God, this is very simple. It's just like food and sex. Like, why I'm complicating life to try to bring everything, where." So, yeah. Okay, let's move on, because I think we can talk about this all day. But I
Yes.
want to really tap into, because now to have a normal sex and proper sex from the man perspective, this is a condition that I actually learned later in life. I don't
Mhm.
Because I'm a physiotherapist. We didn't really learn in school, interestingly, about Peyronie's.
Mhm.
So, what is Peyronie's disease?
It's the greatest of all taboos. This is such a horrible disease with a high number of men never going to any doctor's office. So if you look at the epidemiological data, they will tell you 1 or 2% of the population will have this. But I'm seeing so many men, I think it's got to be around 10% of the men who will get this in their lifetime. And this is an inflammatory process of the tunica albuginea, this firm sock I've been mentioning before,
Yeah.
which comes about of different reasons. We don't really know why this happens. There's some genetic disposition for this. Sometimes diabetes will also make you prone to getting this. Most of this is most probably due to trauma during sex. And all of this leads to an inflammatory process in one spot of this tunica. And what this does is that it becomes very hard and firm and rigid in this spot, which is bad, because when the penis then expands, it won't expand in this spot. And this will cause the penis to bend. And it can bend in all kinds of sides. Mostly it's up or left or right. And if you're lucky, it only bends slightly, but this will go on for like almost 2 years. So during this process, the penis may reach angles which can get up to 90, 100 degrees.
Oh my
That's
God.
really crazy. The penis will shrink about 1 to 2 centimeters, so about an inch. There will be erectile dysfunction. And sometimes I also see a special kind of erectile dysfunction, which is called the cold glans syndrome, which means that the glans, the tip of the penis, is not erecting anymore, which is a big problem when this happens. So the rest is firm, but the glans is not erecting. So it causes real trouble in intercourse. What else? There was some pain in the beginning. So everybody who is experiencing pain with erections, I think they should take some action, because this may be a sign of Peyronie's disease. So this is what I see quite a lot. And I personally think that there are several kinds of Peyronie's disease. I've never read this anywhere, and I've talked to colleagues,
Okay.
and I've had some discussions about this. But I sometimes see patients coming to my office, they have these calcified plaques. So when it's hard to call this a plaque, and there are different kinds of plaques. So there are basically the calcified plaques, which means there is calcium in it. So upon ultrasound, you see this. So it's a white spot on the ultrasound. It's almost like a stone. And then there are the non-calcified plaques, so where you don't have any calcium entering the plaque. And with the calcified ones, I very often, when I palpate those, I can just move them around, these plaques, and then the non-calcifies, they're mostly like a big mass inside the penis. Sometimes you can't. I have 2 or 3 patients where I can't feel anything. I can't see anything. Still the penis bends. This also seems to be some kind of variant of this disease. I was talking to a colleague a couple of months ago. He said eventually every patient or every Peyronie's disease will calcify. I'm not quite sure about this. I saw a patient just last week. He got Peyronie's in 2012. So it's 12 years ago, and he still hasn't calcified. So I think there's several different kinds of Peyronie's disease. But in the end, it doesn't really matter because the penis bends. It matters for me therapeutically because I'm about to give up about treating calcified plaques. I think I almost have reached the conclusion that if you have a calcified plaque, you just have to wait until this settles down after 2 years, 2.5. If it's bad, you have to operate this. I've tried several approaches because, it's bad if for the next 2 years, your penis is in danger of bending and it will increase to bend maybe. Then you want to take action and you don't want some doctor who says, well, we wait 2 years and then we see what happens and then we're going to operate on you. So many men don't want to get an operation. So I think what one can try is to try to stop that. And we have some drugs which theoretically will do that trick. It's no longer Potaba. Potaba is some drug that's out of the guidelines. I'm talking about PD-5 inhibitors, mainly tadalafil, which in theory would do this, and some antioxidants. And then we could try with multimodal therapy to stop this. And it works. So also with shockwaves, if there's a non-calcified plaque, because when we're talking about shockwaves, what I find, and I just treated a patient today with a non-calcified plaques, these things get really soft, and the patients, they then feel the plaque themselves, and they say, "Wow, I almost can't feel it anymore. It's almost gone." Problem is, this is only good for 3 to 4 days, and then it hardens up again. But I think doing shockwaves, making the plaque soft, applying traction, because I think traction is one of the main things that you have to do when you have Peyronie's disease. You have a chance of doing something for the curvature. I succeeded with this a couple of times, but I have to say most of the time it's not working. And I wouldn't be able to tell you who are the patients where this is effective and who are the ones where this is not effective.
Okay. So what is traction for people that don't know? Like, is it a special device or they just...
Yes, there are penile traction devices. There are companies who manufacture them. And if you look at them, you have to get used to them. Let's say it this way. There's some devices which really can bend the penis in the right angulation, and there are other ones, most of them, that just will stretch the penis. The bending ones, you obviously can just wear for half an hour, 1.5 an hour every day, whereas the other ones, it's almost like a hobby, so you have to wear them 3 to 8 hours a day.
So Shockwave, the traction, does PRP has any effect, or is there any injectable or anything that would help dissolve this plaque?
Traditionally, we started off with collagenase. Collagenase is derived from bacteria, and this eats up collagen. And I was telling you about the collagen of the Tunica albuginea. And when it hardens and you inject collagenase, it will then eat up the collagen. And ideally, it would eat up the collagen that is causing this problem, the excess in collagen. This drug is no longer available in Europe because of the pricing. So it doesn't have anything to do with efficacy, but you still can get it in the US. There are some risks involved with this because if it eats up collagen, you have a risk that it also may eat up the collagen that you don't want it to eat up, so the tunicale can burst. This is one of the problems. It's not happening very often, but it indeed is a risk that this can happen. And you can be prepared that the penis will look terrible for like 2 weeks after the injection. I've done this in a patient, and because you get bleeding when you do this, it's just part of the deal that it will bleed because of the collagenous, but usually it's not a problem. It will fade away, and it won't be a problem. So this is one of the things that you can do. I have started to do platelet-rich plasma.
Okay.
Which is derived from the patient's own blood. And the principle is that I insert the needle in like a tunnel into the plaque in different places, and then I insert the platelet-rich plasma. And this is derived from the blood in a way that I take, for the moment, 60 milliliters of blood, and it boils down to 4 milliliters of PRP. And what this contains is plasma, so it's the fluid of the blood, and platelets. And these platelets, for the time being, they are concentrated by the factor of 10. So they're very highly concentrated, and platelets, have growth factors and things that could counteract this process. But still, PRP is not the officially approved way of doing it. So it's more like outside of any guideline that this can be tried. And this is the same with stem cells. So this is the other way that you can do. You can get stem cells from, mostly it's derived from fat, and then preferably from body fat from the belly, where you can, it's like a liposuction when you go for cosmetic surgery and you want to get leaner, and they put in this big needle and they suck out the fat. It's almost like that. And then you have a special device where you can just centrifuge the fat, and then you get stem cells, and you can inject these stem cells into the plaque. I've talked about this with one colleague in Denmark, and I also uploaded 3 videos about it. It was in May, and she had done this at the university, and she told me that she had some patients where this worked beautifully, and then they had the majority of patients worked a bit, and then you had some where it didn't work. So you always have to try, and you can never predict where this is going to be work or if it's working at all.
Yeah, and this is probably the message in the end for like Peyronie's, you have to try it. It's something that because even for Shockwave, like studies, show that it is effective, but then, when you do a study, it's more in kind of controlled settings, which is great. Like it confirms, but we're talking more about like real world, what patients, what we see from our personal experience. I don't do any men's health. So it's just, we have a physiotherapist that it's, trained, and he performs those.
What's really working in Peyronie's disease is pain. So erectile pain will be treated beautifully by shockwaves. You do 4 or 5 sessions of shockwaves, it will go away very quickly. And this is the only thing that I can really predict. So we can make this go away, the erectile pain. But just to put this into perspective, like we were talking about, we're going to talk about pelvic pain.
Yes.
Peyronie's disease, ED. So where do I see shockwaves in this scenario? I would say effective-wise, I would put Peyronie's disease at the lower end of the list. So if you're looking for a miracle, you should look for pelvic pain, which we're going to talk now.
Let's talk about, because I can't wait about this actually. So,
ED is in the middle. So ED gives very good results. But if you're really looking for miracle cures, you want to go for pelvic pain.
So what is pelvic pain?
I don't really know because it's pain in the middle of the body. And there's several things that can hurt. It's the bladder, the kidney, not the kidney, the bladder, the testicles, the urethra, the prostate, everything which is down there, and we have different kinds of pelvic pain syndromes. But what it really is, we don't really know. But due to my experience with shockwaves, I think much of it is just muscular tension in the pelvic floor. And I know many people don't know what's the pelvic floor. It's, I have a model. Should I get it? No, it would. No, I'm just describing it.
Let's describe it for people that don't see the video. So description
so the pelvic
is
floor.
better,
So if we didn't have a pelvic floor, simply our organs would drop out of the body. So it's the end of our body. So we have to have something that keeps the organs in place. That's part of the deal of the pelvic floor. We are talking about several layers of muscle, which work together and work independently and work in patterns to promote certain functions of the body, which is, for example, coordinating the upper body, the movement of the upper body with the lower body. This is what the pelvic floor does. And this is a very important part, this coordination part. Then if you go to the bathroom, like doing number 1 and number 2, this is what is also coordinated by the pelvic floor. And last but not least, it's sexual function. And for some of these functions, the pelvic floor has to contract. And for other functions, the pelvic floor has to relax. And for this to work properly, you need muscles that can relax and that can contract, which is very easily disturbed by certain things that we do. Thus, for example, something that women do very often is when they go to the bathroom, not at home, but other places, they do something like hovering. So they hover over the toilet bowl. And then you give the pelvic floor the instruction to coordinate this hovering movement by contracting. At the same time, you tell it to relax. So otherwise you couldn't take a defecation or whatever. So this makes it very difficult for the pelvic floor. It gets confused. And as a result, it may easily get a permanent contraction, so an overactivity. If you sit a lot, if you have any kind of disbalances, if you have psychogenic issues, like you have lots of problems in your life, you easily start to contract. Everybody knows this because we have this in our language. So we say, if you're not in a good mood, chin up, stiff upper lip, keep your chest straight, or whatever we say. So we use in our language metaphors for telling people how to cope with psychological problems and the everyday problems that we have. Like we have a colleague at work who's a jerk, or whatever is happening. So we have to pay bills and we can't pay them. All these kinds of troubles. So we tell ourselves to sit straight, to walk straight. And this is a metaphor for muscular tension. And we can do this in the back, but we can also do this in the pelvic floor. And some people do. And especially in the sleep, and some they press their teeth or their jaws, and they do everything. We have, this as a physiotherapist, right? People who come with neck pain because of tension building up in the neck muscles. Yeah. It's the same with the pelvic floor.
I just wanted to add actually something, because this is my expertise now, when it comes to the muscle part. So pelvic floor, it's actually considered the diaphragma. So we have 3 diaphragmas in human body. We have the cranial one, like on the head. Then we have the one that separates the lungs and the abdominal organs. And then we have the pelvic floor. So every time when you take a breath, your abdominal diaphragma actually raises up, which creates more pressure on the pelvic floor. So that's why you need that diaphragma to be stronger, and you need the cranium. So they actually work all together. And then The most common one that I see, when it comes to pelvic floor dysfunction, from my perspective, that is related to our habits and not related to our habits. So number one, it's like sitting for a long period of times. That weakens these muscles. Or if it's a stressful job, as you said, we tense up. Some people say, oh, we carry the tension all on upper back and neck. And some people say, oh, I carry the tension on the lower back. But I don't think so. It's a lower back tension. It's a more pelvic floor tension that gives the symptoms as a lower back. And then the number one cause that is not related to the habits that I've seen is surgeries. C-sections, appendectomies, any kind of surgeries, during delivery, for example, for women, if there's any tearing, that's another thing that kind of affects the pelvic floor muscles from what I call it the software perspective. So, yeah.
Yeah, and then what happens in men's health is erectile dysfunction, also most probably some kind of premature ejaculation. It can happen. Pain in the testicles, for example. So people don't understand. So they come in with pain in the testicles and they think there's something wrong with the testicles, but there's something wrong higher up. And I try to explain them the concept of referred pain. That's what we call it, when the source of the pain, what's causing that, is at another place than the pain that's appearing. Many of you may know this from the heart. Like if you have a heart attack, it can hurt here, but sometimes it hurts in the arm. So why is it hurting in the arm? Because there's no heart in the arm, because it's a referred pain. So the nerves, they refer to the arm and it hurts in the arm, and the source of the pain is somewhere else. So it's the same with testicular pain and pelvic floor dysfunction. So you have an overactive pelvic floor and it hurts in the testicles or in the urethra. Sometimes overactive pelvic floor can also cause very funny urinary urgency. I see this quite a lot.
And this is for both for women and men?
Yeah, it's also for women, as a matter of fact. So they can have pain syndromes, vestibulitis, which is called, everything. So there's some similarities between women and men.
Okay. So there is, especially in Canada or in North America, there are a lot of pelvic floor physiotherapists, and this is one question that I would like to ask you as an expert in this field. So, and the most common exercise is Kegel exercise. So, is this a good exercise? Because when you search it, you see like, okay, Kegel exercise, the number one exercise for strengthening the pelvic floor muscles. How beneficial is this exercise, or can it do harm or good, or what is your take on this?
I think Kegel exercises are excellent after delivery. If you're a woman, they are excellent after radical prostatectomy for prostate cancer, and they are very good if you have a weak pelvic floor. And these, if we're talking about men, men with a weak pelvic floor, I think they have to be 75 or 80 years old, more or less.
Wow.
Or you have some kind of disease which is causing this. But for a healthy young or middle-aged man, I wouldn't recommend doing Kegel exercises, because they, as a rule, they don't have a weak pelvic floor. If so, they have an overactive pelvic floor. I do lots of examinations, so I'm old school. I like to examine my patients. I know this is out of fashion, so people rely on labs and x-rays and stuff, but I really touch my patients and try to find with my hands what's the problem that's causing their troubles. So I look for the pelvic floor almost in every patient, because I want to get an impression how's the pelvic floor working, even if they don't have pelvic floor issues they're coming in with. So it doesn't it doesn't hurt to do that, because if I do a prostate palpation, I assess the pelvic floor at the same time. So I make them squeeze my finger with the rectal muscle. Sometimes they don't understand. So I say, can you squeeze my finger? And then they squeeze their hand. So, but if you look at the data and the research, it says that I think it's almost a third of women and a quarter of men who can't contract the pelvic floor. And it's true. I see this very often, that they are unable to contract the pelvic floor. Not everybody can do that. So what you see is that they move their buttocks or they move their abdominal muscles in order to try make the pelvic floor work. So we have to have this in mind, that like if we talk Kegel exercises, or if you talk strengthening the pelvic floor, they have to be physically able to activate those muscles, and not everybody is able to do that. And this is one thing about Kegel exercises. But what I find is that many men have normal pelvic floors or overactive pelvic floors. And I always say, if a man with an overactive pelvic floor, they can crack walnuts with their rectum or with a sphincter. It's so tense. And some of those I can't even insert my finger. It's so tense. So if you do Kegel exercises, strengthening exercises on a tense muscle, it's not good. Like most of you would be able to imagine, like you have a sore neck because it's so tight and tense, and then somebody tells you to do military press. It's not good.
Yes, yeah. Huh. So if a man has overactive pelvic floor muscles from a sexual dysfunction, could this cause ED? Or
Yes.
like premature ejaculation as well?
Yeah.
Or
you have to think about where these muscles are attached. So we have, as I said, we have different muscles in different layers, and there have two muscles which attach directly to the penis. What I see in these men is also post-micturition dribble. Traditionally, if you look at the traditional urological literature, they will tell you that post-micturition dribble is the result of an enlarged prostate. So problem is, I also see post-micturition dribble in 20-year-old men, or even younger.
So just to explain this is when you pee, right? And there's still some drops left, correct?
Yes, and you can't get them out because the urethra is shaped like a U. So when you're done peeing, it has passed the sphincter muscle and it's still in the urethra, but it can't come out because you have this U shape. And then it's just lying there. And you get dressed and then you sit down, and suddenly, because now it's the pressure onto this U, some drops come out. This is what we call post-micturition dribble. And young men don't have an enlarged prostate, but still they have this. So we have two muscles, essentially, which are attached to the penis and the urethra, and they contract when you're done with peeing.
Yes.
And this evacuates the urethra, the U, from the urine. And when these muscles are overactive, they are not able to do that. So you have to think about this action, this pumping action, that a muscle that's this size will contract to this size, and then it will just pump out the urine. So if you have a muscle that's this side, because it's overactive, it can't really pump out the urine. See, this is what's happening. And this is what's happening in post-micturition dribble, but also in erectile dysfunction. So for some reason, this is connected, and then the penis won't be able to hold the blood for some reason. And I found out about this by chance while treating patients with shockwaves for pelvic pain, because we are starting off saying that this is a miracle treatment, right?
Yes.
So if you have pelvic pain, and then you have a good chance, if this is overactivity, that this will be cured by shockwaves. And the first patients I had, that was really unbelievable. So my first patient was a friend of mine. He had been diagnosed with chronic non-bacterial prostatitis, and he came driving 300 kilometers to my office. When he got here, he was crying. He was literally crying. He couldn't sit on a chair because it hurt. He was leaning, he was kneeling on the floor because it was the only posture he could keep, and he was really crying. He was really a mess. So I had heard about this effect of shockwaves on this kind of patients. So I told him, so you've got to be number one. Because before that, I had some patients whom I had thought, well, they are candidates. But you know how it is. Nobody wants to be number one. They don't want to be the lab rat, so to speak. But he was so devastated. I told him, you've got to be number one. And then I treated him, and I hit all these trigger points. So normally shockwaves don't hurt, but if you hit trigger points, which are tender spots in the muscle, which in an overactive muscle, that really hurts. So you have to really adapt the strength of the shock waves to treat these trigger points. And it really hurt him. But after 6 weeks, he was pain-free, and he still is up to today. So it's 4 years ago. He still is pain-free. So this wasn't chronic non-bacterial prostatitis. Obviously, it was some kind of muscular problem that I resolved by doing the shock waves, because they resolved this problem. And then I was very lucky that I got a huge wave of patients flooding my office. That was in the beginning of the COVID pandemic, maybe because everybody was sitting at that time.
Yes. Yeah.
And I think the first 10 patients, it worked beautifully. So everybody got cured. And it was like a miracle. And I thought that can't be true, because in medicine, you never get 100%. And right I was, because then one after one, I discovered patients where I couldn't help. But I would say, if I select my patients right, I would say I've 60, 70% success rate. And one of these patients, we never thought about erectile dysfunction. They then approached me and said, well, doctor, is this normal? Now I can drill my mattress at night with my erection. and this was new to me, because we never talked about it. And I didn't know that he had erectile problems. So I started to ask all of my pelvic floor, pelvic pain patients, what about erections? And some of them said they were bad, and then they would be better. And amazingly, some of them said, well, they're normal. And then they said, oh, they're better. So I found out that the pelvic floor and pelvic floor overactivity plays a big role in erectile problems. And I think this is one of the main points we're missing when talking erectile dysfunction and shock waves, because it's not only vasculature, it's also muscle. And we tend to forget that. And I think results may be blurred, or what can I say? This is a confinder when we leave out the pelvic floor and we don't assess the pelvic floor, because the effects also in terms of erectile function, if you have a pelvic floor patient, they're also amazing. Erections get really better. And maybe some of the effects we're seeing in these large-scale studies are due to pelvic floor overactivity. Maybe that's blurring the whole picture. I don't know.
Yes. Yeah, it's very true, because see, when it comes to a problem, anything that we experience as a humans, it's never one factor. It's never one thing. So diagnosing it's the key, and that's why we have to look at human body as a one single tissue and one single structure. And it's interesting. This is just my personal experience. As when I founded On Pain Clinic, when it came, all my therapists were saying, it's like, okay, we have to charge like everybody else, based on the condition. And I said, like, no, because how can you allow the client to say, I have erectile dysfunction because of this, and then we're just going to treat you as a label instead of treating you as a human. So I said, okay, people are going to come in, they're going to book for, their main concern. but then the therapist is going to decide, and it's going to determine to treat whatever it takes to correct that main concern. So even our services are actually based on that. So we don't give you a menu like a restaurant where you say it's like, okay, you're going to pick this and this is, and then we only look at that. We don't look at anything else. No, if there's an issue, come, let's assess, let's look at them, let's figure out. And you are another human that I know from people that I know from my experience, that you look at, even though you're trained as a medical doctor, you have all this expertise, all those specialties, you actually look at human body as a one single system. And thank you for that. Thank you for shedding light into all those things, Stefan. So
thank you, Uran.
Yeah.
But with what you said and with the approach, there's one problem. There are certain diseases people don't want to have.
Yeah.
And they discover, like, if somebody comes into your office and he has erectile dysfunction, and you diagnose sleep apnea, people don't want that. They also have an expectation on what disease they want to have or the underlying cause. I discover this sometimes. They're not satisfied with what I say, so they want to have it in a different way.
True. Very good point. Very good point. So we still have to support them, until they're convinced, or till they listen from an expert. And I understand that, because people, I think, go sometimes from a past experience. They've been to so many doctors, they've been to so many therapists, and they're all great. All healthcare providers, they're out there to help you and to help people. There are some that they just do that bare minimum, and then they miss the rest. And that's why I think people end up in so many vicious cycles. So but just being for them and kind of trying to convince. And one good thing with Shockwave is that it's a tool that usually give that instant relief, or change. So then it makes a lot of people to actually start trusting you and believing in you, especially when they're meeting you for the first time. So
I think we have to mention one very important point, and we didn't talk about this.
Okay.
When we talk shockwaves, we are talking shockwaves and not radial pressure waves. I think this is very important. And this is also one of the reasons why shockwaves may not work the way they're supposed to. You're doing radial pressure waves as well, right?
Yes.
So there's an indication for radial pressure waves, and there is an indication for shock waves. So where's the difference? A shock wave is a kind of acoustic wave which has very unique features and properties. So there's usually a very steep rise in pressure, and it's a tsunami that's flooding the cells of the body. And then this is only very, very short seconds, nanoseconds. And then you get a negative pressure, because then it subsides so fast that you just, the cells are kind of sucked towards the source, pulled back. Yes. Yeah. And this is a shock wave. So this mechanical stress that's put onto the cells is doing some unique features, like activating stem cells and all the things that we said. Whereas a radial pressure wave is also some kind of acoustic wave, but it's more like a sound. A shock wave travels faster through a given medium than sound. That's one of the definitions of shock waves. The way of distribution in radial pressure waves is totally different from shock waves. So they stay more on the outside, they distribute more unevenly, they are not focused. Shock waves are usually focused. So this is why they feel like needle pins sticking your body. This is a focused device, and pressure waves are unfocused, and they are brought about by essentially pressing air. So this is a ballistics thing. You accelerate a projectile into a tube, and then air is pressed together, and this is like coming out like a blow of air. Whereas in shockwaves, you need a kind of medium to produce a shockwave. So there are several modes of how you produce a shockwave. So it's electromagnetic, electrohydraulic, or piezoelectric. So it's crystal or magnetics or some kind of foils that you depolarize to bring about a shockwave.
Yeah.
And I think this is very important to keep this in mind. So there's so many devices and methods labeled as shockwaves, which are not. And it's difficult to find out.
I know, Stefan. This has been our main challenge since day one, and I never stop, educating practitioners and patients and people about the difference, because you know what is our biggest challenge, is our clients come and see us, and they're so happy. They're trying to convince now their best friend. I had so many people that paid for them. They said, "Hey, I know that you don't know what I'm telling you about, but I had this amazing experience. I'll pay for your treatments. Just go and try." And then some that say, "Oh, I found Shockwave cheaper because radial pressure wave, the sound that the one that sounds like a jackhammer, that's not the true shockwave." So then these people go and get that. They don't get the results, and they say, "Oh, Shockwave, didn't work." But it's unfortunately, especially in North America, because there's no regulation for shockwave, and especially for men's health. If you're a man out there and you think you had a shockwave, or you find a shockwave place and the technology sounds like a jackhammer, that's not a shockwave. Okay, so the true shockwave, you don't really hear it. It's like it's very sudden, only in very high intensities. And this is just like a side note here. I have a company, it's called Medical Shockwave Institute, where we teach actually and train practitioners in the proper use of the shockwave. And Stefan is actually our main instructor to train practitioners how to use shockwave properly on men's health. So if you're wherever you're in the world, you can go to actually just iloveshockwave.com. There's a section where you can look and find practitioners that are trained by Stefan in the proper use, because this makes a huge difference. Like with true shockwave, even during the treatment, it's actually less painful. I cannot imagine to put the jackhammer on the penis or even in the pelvic floor muscles, because the skin is so thin. The impact from the radial, it makes it very discomfort or painful. So many people complain that shockwave hurts, but it's the radial pressure wave. It's not the true shockwave. So thank you, Stefan, again for shining light even on this big issue.
Thank
because,
you.
Okay, this is going to lead to one more.
Just, I don't want to condemn radial pressure waves. It could be that they're working, but we don't, for the time being, we don't have enough or sufficient scientific data for doing so. But if you want to have smooth skin in your face, go to Uran and get the jackhammer.
Yes,
because this is one of the indications for radial pressure waves. So it smooths the skin. So different indications. So you have to have the right method for the right kind of disease or what you want to treat. So
correct.
Also, radial pressure waves are effective, but for the right things.
Yeah, we use it a lot. It's just for men's health, when it comes to men's health, because there are companies in United States, especially, or in North America, that they promote shockwave treatments for men's health, but they don't use the true shockwave. Then there's another thing that I wanted to mention. I've seen some like home devices that they call it like shockwave for home use, and they're using actually a type of radial pressure wave. So again, any stimulate's a stimulate. It can have, biological effect, but everything that we talked so far about shockwaves, we were talking about the true shockwaves.
And then what I find is due to my YouTube channel, I get lots of comments from the US because they are the main viewers of my channel. There is a big difference in the way people perceive healthcare and also in the systems in itself, and the way you're allowed to promote things. It's a big difference between the US and Europe. what you're
Yes.
allowed to do, what you're not allowed to do. And as a result, I see many patients being very skeptic against doctors. So, like, in a sense, they want to rip you off. And this is why it's so expensive. So they buy the cheap radial pressure wave machines because they think then they're not getting ripped off, but in fact they are, because then they're buying some kind of junk
Exactly.
that's not working.
Yeah.
And
Honestly,
you have to think that you were telling me about this machine the other day. Shockwave machines, real shockwave machines, are expensive, and maintenance is expensive, and this is why treatment is expensive. You have one electrohydraulic machine that 100,000 shots, and then you have a couple of $1,000 for a new transducer.
It's 50,000 shocks, so it's like it spans, it burns like 4 cents per shock for us. Like imagine that. So and yeah, this is exactly what I wanted to say. It's like the reason why true shockwaves are expensive is because of the technology, is the consumables, is the investment cost, is the cost of running those devices. But in the end of the day, it's all about, quality in life. Personally, I rather go and pay more for better quality, especially when it comes to my health, because if I'm cheaping out for my health. I'm not doing that for the doctor or for anybody else. It's for my personal health. So I rather put things that are always better. Okay, Stefan. So I think we should start closing this episode, because, as I said, we can talk for hours here. So there is I have 2 more questions. So is there anything that I should have asked you and I haven't asked you so far?
We were talking about everything.
Yes.
I can promote my YouTube channel.
Yes, yeah. That's the next one. Is like, where can people? Because here's the thing: we got this. We have Stefan here for an hour and 20 some minutes, but this is like one episode. And if you want to actually get Stefan anytime you need, and in weekly basis, then where they can find you?
It's mainly on YouTube, and the name of the channel is Uro channel. It's URO, like urology, and then channel in one word. I'm posting 2 times a week. It's mostly sexual medicine. I'm also doing live streaming. So a couple of weeks ago, I started live streaming on Fridays, where I go through some topics. It's very much fun, and although I was telling you I get some critical comments, most of the comments are very nice, and I've great fans, and they support me very much. And it's a good thing to know that I also seemed to have changed some lives to the better. So I got one comment the other day is telling me, well, because of my channel, he stopped smoking, and I was so proud that it happened. So I think it's important to try to make a difference.
Yeah, and this is the thing, Stefan. Is like we're both healthcare providers in different fields, and anybody who has decided, to become a healthcare provider, they do it from their heart. So even this episode here, like, it's our time, it's your time, my time. We're in 2 different zones. We're connecting through those means. So nowadays, knowledge is free. And you have good people that are trying to help you, and they're advising you. But in the end of the day, you as a human, it's your own responsibility to make the changes. So it's very easy. Just if you want to make the change, it is possible. So thank you again, Stefan, for bringing all this information. It's just, since the time I know you, I've learned so much about men's health that is changing my life, first. And then I actually use Aura Ring to measure my sleep and all that stuff. So it's just kind of confirms like everything that I'm doing, because my friends laugh at me. It's like, why I go at the same time, to bed. It's like same time I go to bed, same time I wake up, but I'm going to start teasing them. And I'm just going to say it that if you know why I go to bed, at the same time I get up and I pay so much attention to my sleeping patterns, ask my wife. So so if there is anybody, you know, in Germany or anywhere in the world, that you still practice, you still accept clients,
Yes,
you can still
absolutely.
help people
I
in
have a
getting get.
full going practice. So, yeah, absolutely. You can find my website at www.buntrock, B-U-N-T-R-O-C-K, not slash, it's minus urology, but with IE at the end. It's German.
Yeah, we'll put it on the show notes here.
Yes.
And you're very famous. So
No.
all it takes is like just to put the name on Google, Dr. Stefan Buntrock, and it's easy to find. You already have over like close to, I think, 250,000 people that follow you on YouTube. So whoever's listening, go and subscribe, go and follow Stefan, and he's gonna be almost like your virtual guide towards your health and improvement. Okay.
Thank you very much, Uran, for having me on the show.
Yes. Thank you, Stefan. Thank you. Thank you for your time again.
Thanks.
And thank you,
Bye-bye.
everybody. Yes. Bye-bye.